Hi everyone, good morning guys, good morning all of you. So today we are going to discuss some miscellaneous questions from all the topics, the frequently asked questions. That means they have been asked very many times in the previous years, right? So that means they are hot topics. So I have chosen such questions for you, and that is what we had in the Telegram quiz yesterday. So shall we start? Are people joining us? All right. Good morning, all of you, those of you who have joined. So we'll start with this FAQ quiz. I hope the Sunday morning is going well for all of you. All right. So which of the following is a cause of pan-uveitis? Now, what is pan-uveitis? So pan-uveitis is when you have inflammation of all the uveal structures. Yes. So what are the uveal structures? From anterior to posterior, you have iris, ciliary body, and choroid. Right. So all the structures are inflamed at the same time. That is pan-uveitis. So this is a question which is asking you which is a pan-uveitis. So let's take a look at the options, because now I can't guess because there are so many causes of pan-uveitis. Now we have to take a look at each and every option one by one. Okay. So let's take a look at option A, lens-induced uveitis. Now why would there be a uveitis because of lens-induced uveitis? Now I'll tell you a very simple way to figure out whether it is, first of all, whether it's a pan-uveitis, anterior, intermediate, or posterior uveitis. See, lens is an anterior segment structure. You all know that. So when you have a lens-induced uveitis, or what was an older, fancier name, it was called phaco-anaphylactic uveitis. So it was some kind of allergy that they thought. Okay. So phaco-anaphylactic uveitis or phaco-antigenic uveitis. But currently it's called lens-induced uveitis. Okay, so it is an anterior uveitis. Alright. So for some reason the lens protein leaks into the aqueous and the body's immune system has never seen this lens protein. Why hasn't it ever seen? Because it has this Z category security. You know, like many of our politicians who don't deserve, they have Z security, so they don't have to be frisked, right? At the airports, no way. Right. So just like that, this lens protein has this Z security, or what I mean to say is the eye is an immunoprivileged organ. So it does not have to display its antigens during development. So the body's immune system is simply blissfully unaware of the existence of lens antigen. Yes. So for some odd reason later in life, either because of a trauma where the lens capsule is breached and the lens protein escapes into the aqueous, or after a cataract surgery, probably we've not removed the cortex properly. There is some cortex remnant, and the body's immune system starts reacting to it, you will get a uveitis, and that would be an anterior uveitis and typically a granulomatous anterior uveitis. Okay. So definitely not option A. Option B, Fuchs uveitis syndrome, that is your Fuchs heterochromic iridocyclitis. Now, Fuchs heterochromic iridocyclitis is a non-granulomatous uveitis. Okay, so these stellate or the star-shaped keratic precipitates that you get in Fuchs, they are tiny ones. So this is a non-granulomatous. Okay, Fuchs is a non-granulomatous uveitis. Put it in your brain box. Fuchs uveitis or Fuchs heterochromic iridocyclitis is a non-granulomatous uveitis, and it is primarily an anterior uveitis because we call it as iridocyclitis. Iridocyclitis is anterior uveitis, no? Although you might have a little bit of vitreous cells, but that doesn't make this a Fuchs into an intermediate or a pan-uveitis. It is primarily an anterior uveitis because remember the other name, Fuchs uveitis syndrome, FUS, or FHI, iridocyclitis. Iridocyclitis is an anterior uveitis. Yes. So that is not the answer because our question is which of the following is a pan-uveitis. Okay. Next one, Behçet's uveitis. Behçet's uveitis. Now I do not know. I have heard of Behçet's uveitis. I know about the transient hyperpion, and I also know there is occlusive retinal vasculitis in Behçet's. Now I am confused. But anyway, let's look at the option D because A and D we have ruled out. Option D, HLA-B27 uveitis. It is primarily an anterior uveitis. Yes, it is primarily an anterior uveitis. HLA-B27, we all know that. Yes, acute anterior uveitis. The most common cause of acute anterior uveitis is HLA-B27. So that is primarily an anterior uveitis, right? So we've ruled out option B. Option C is the answer. So Behçet's is a pan uveitis. Yes, it's a pan uveitis, and typically it is a non-granulomatous pan uveitis, right? So non-granulomatous pan uveitis is Behçet's. Is that clear? Yes, Behçet's disease is capable of causing a pan uveitis and that is non-granulomatous. मैं इतना बोल रही हूँ ताकि आपको मेरी आवाज़ सुनाई देगी एग्जाम में अगर ये क्वेश्चन दोबारा आएगा, ठीक है? Alright, let's move to the next question. Which of the following retinal vasculitis is primarily a phlebitis? Now, why is this retinal vasculitis asked for you? See, retinal vasculitis is actually a part of posterior uveitis. Yes, retinal vasculitis can be a part of posterior uveitis, and also sometimes in intermediate uveitis, the peripheral retinal vasculitis comes under intermediate uveitis, and which is primarily a phlebitis. What is a phleba? Phlebo means vein. So which of the following retinal vasculitis is primarily inflammation of the retinal veins? Now this looks like out of syllabus question. Nobody has ever taught us this. But anyway, and you might also say, ma'am, you also didn't teach me in your videos. अरे मैंने बोला नहीं, but देखते हैं if I have taught you in an indirect way. Option A, Vogt-Koyanagi-Harada syndrome. Vogt-Koyanagi-Harada syndrome is a granulomatous pan uveitis which is bilateral. But उसमें I have not talked about any vasculitis. Now let's look at option B, Eales disease. Eales disease, haven't I taught you what is the other name of Eales disease? What is the other name of Eales disease? Type in the chat box. What is the other name of Eales disease? Do you know the other name of retinal? Okay, what is the other name of Eales disease? Okay, it is periphlebitis retinae. Okay, so Eales disease is also known as periphlebitis retinae. Peri means around, phlebo means vein, a retinal vein, and especially the peripheral retinal vein. It's not the central retinal veins, the peripheral retinal veins. So it is a phlebitis. It is there in the name of Eales disease. ये तो मैंने बताया था वीडियो में जब मैं Eales disease लिखती हूँ. The next thing I tell you is remember the other name. It's very easy to write a short note. It is very easy to crack all the MCQs pertaining to Eales disease. So it is a phlebitis. Okay, periphlebitis retinae. So we've already got the answer, I guess. But anyway, let's take a look at the next option, toxoplasmosis. Now, why is even toxoplasmosis in the options? See, toxoplasmosis has a very characteristic necrotizing posterior uveitis. You know that. Also, it also has a arteritis. Okay, it also has an arteritic element. So that is an arteritis. Which one? Toxoplasmosis. Toxoplasmosis, okay, is characterized by a necrotizing chorioretinitis and also an arteritis. But my question is about retinal vasculitis involving primarily the veins. So option C is ruled out. Option D, Fuchs uveitis. Yeah, Fuchs uveitis is heterochromic iridocyclitis. It's an anterior uveitis. At the most, sort of vitreous cells you have. There's no vessel involvement in that. Retinal vessel involvement in that. Absolutely no. You can take my word for that. So option B is our answer, Eales disease. So what was the question? The question was, which of the following retinal vasculitis, inflammation of the vessels, is primarily a phlebitis? It is Eales disease. Is that clear? Can we move on to the next question? Clear? Pakka everyone? You understood this? Okay, the next question. All of the following uveitis are of sudden onset except, oh my god. Oh, acha, theek hai, dekhte hain. Endophthalmitis. Now, endophthalmitis, is it a uveitis? Yes, it is a granulomatous pan uveitis. Endophthalmitis is a granulomatous pan uveitis. What was the other uveitis pan uveitis we talked about today? Behçet's. Behçet's was a non-granulomatous pan uveitis. Another pan uveitis I just mentioned during this session was your Vogt-Koyanagi-Harada, VKH. It's a bilateral granulomatous pan uveitis. But anyway, the question is totally different. Sudden onset except. Chalo dekhte hain. Posner-Schlossman syndrome. See, Posner-Schlossman syndrome. Remember the other name, glaucomatocyclitic crisis. Let's see again if there's anything else. Sudden onset except HLA B27 uveitis, acute anterior uveitis. HLA, see option B, Posner-Schlossman syndrome. I'm still a little dicey about option B. Okay, so I'm keeping option B under doubt. Option A, pakka sudden onset. Yes, sudden endophthalmitis is a sudden painful decrease in vision with a red eye. So that is there. So that option is ruled out because we are asking about except. Posner-Schlossman syndrome, you also don't know, I also don't know. Let's keep it at that. Okay. Now, let's go to option C, HLA B27 uveitis. Yeah, that is an acute anterior uveitis. You have a sudden painful decrease in vision in a red eye. Yes. Okay, so that is not the answer. Fuchs heterochromic iridocyclitis, it is a chronic one. There's hardly any redness, hardly any pain. Some fine day, one fine day patient will come. Not because of iridocyclitis. Because of the iridocyclitis, he would have developed a complicated cataract and he will come to you because of the cataract. And cataract is characterized by what? It's characterized by a very slow, painless, progressive decrease in vision. So have we got our answer? Yes. Now let's go back to option B. Posner-Schlossman syndrome. Remember that name. Other name. Glaucomatocyclitic crisis. Okay. So patients, although it is a chronic uveitis, anterior uveitis, the uveitis itself will not cause any presentation, but the IOP shoots up so high over a long time, and one fine day he presents you with a sudden onset of painful decrease in vision. Yes. Posner-Schlossman syndrome. Although the eye may be a little white, it may not be red, and he will characteristically have a dilated pupil. Is that clear? So, among these options, so let me read the question again for you. All of the following cause sudden decrease in vision except option A, endophthalmitis. Yes, it causes. Posner-Schlossman syndrome. Yes, it causes. Then option 3, HLA B27 uveitis, yes. Acute anterior uveitis, yes, it causes. Option D, Fuchs heterochromic iridocyclitis, no. That is a cataract which causes the patient to come to us. Or it's an incidental finding. Is that clear to everyone? Good morning, BU. Good morning. I missed you the last 2 days. Yes, Krishna. It may be recurrent HLA B27, but what we are exactly talking about is the sudden decrease in vision. Is that clear? So our answer here is Fuchs. Okay, next is okay, it's a fundus image. All right. So let's take a look at this fundus image. So today you have 2 fundus walks, one in the morning, one in the evening. So we are having a fundus walk session at 5 p.m. All right. Today again we are having a YouTube session. So 5 p.m. will be our fundus walk session and 6 p.m. will be our images decoded session. So 6 p.m. I will be discussing all the images that I had posted through the last 1 week on Instagram. All right. Okay. So let's take a look at this particular question which also has a fundus for you. So you got okay, I don't know. There's a lot of reflection. All right. So here you're seeing a mixture of red and white, yellow dots. Can you see a lot of red, tiny red dots and tiny yellow dots? So these tiny red dots are your microaneurysms. Okay, so these are your microaneurysms, and a little bigger red ones are your dot blot hemorrhages, and the yellow ones are your hard exudates. So actually this is non-proliferative diabetic retinopathy. I have put up another video for you on YouTube marking all the findings for you. I will share the link of that image at the end of the session in the comments section. Go and watch it. So NPDR. Now even if you didn't know this was NPDR, let's look at the options. Sickle cell retinopathy. See, sickle cell retinopathy will be more peripheral findings, not bang in the center, in the posterior pole. Okay, and you will have a characteristic CFAN neovascularization. That's a one-liner MCQ. And retinitis pigmentosa, I've again put up a video for you on Instagram showing you the calapuchis, the black insects crawling from the periphery. So there is no black insect here. There's only a combination of red dots and yellow dots. When you see just red dots and yellow dots, it is non-proliferative diabetic retinopathy. Central retinal vein occlusion, it's a splash tomato appearance. There is no splash tomato here. There's not so much of red hemorrhages. Can you see that? So it's just a mixture of a few red dots. So you can see the optic disc here and the macula here. So that means this is the right fundus, and in the posterior pole in the central retina I have all these findings. Is that clear? Oh, all right, BU, no problem. Watch the videos after, okay? So the answer is NPDR. Now I'll share the link for the NPDR, and evening session probably we will discuss CRVO. So evening fundus walk, please join us. All right, next question. All of the following are true regarding rhegmatogenous retinal detachment except, yes? So rhegmatogenous retinal detachment, the word regma, like reshma, no? Regma means tear. Phar diya kisi ne, khichtanga. There's a tear, okay? Koi ched hai. So that is a retinal tear, right? So let's find out what they want to ask. All the following are true regarding rhegmatogenous retinal detachment except. So we need to find out the false statement. Detached retina is convex and irregular. Oh hey Baba, I don't know anything about this option. Let me go to option B. Tobacco dusting of vitreous. Yes, tobacco dusting of vitreous is there. What is tobacco dusting of vitreous? Also known as Schaffer's sign. Okay, Schaffer's sign or tobacco dusting of vitreous is seen in rhegmatogenous retinal detachment. So option B is true. That's not the answer. Option C may occur if HSV posterior uveitis is not treated. Hey Baba, I don't know about this also. Now what is this HSV posterior uveitis? You know what is HSV posterior uveitis. See, I've taught you HZ, varicella zoster virus, that causes PORN. Yes, the immunocompromised individual is affected by VZV and it causes PON, progressive outer retinal necrosis. HSV causes ARN, acute retinal necrosis. Agar retina is getting necrosed, meaning it's getting decayed, no? Necrosis, you know what happens. So the retina is going to become thin. So far jayega na, it will easily tear and you can have holes. So it becomes a thinned out retina. Any necrotic tissue will cheese wire, right? You all know that. Any necrotic tissue will cheese wire. So something like that is going to happen on the retina also. So you know it. It is just an indirect way of putting it. Yes. So HSV causes in posterior uveitis, and what is the entity called? It is called ARN, acute retinal necrosis. So when you have a necrotic retina, especially at the edge of that lesion, you will have retinal holes and very thin retina. So there is a possibility of a rhegmatogenous retinal detachment. So that is why you need to treat it. Is that clear? You understand? Yes. So that is true. So may occur, rhegmatogenous retinal detachment may occur if HSV posterior uveitis is not treated. It is true. Option D, fibrous bands are seen in the vitreous. Yaar, now look at this. Fibrous bands, do you see it in rhegmatogenous retinal detachment? Which retinal detachment do you see fibrous bands? You put in the options. Fibrous bands in the vitreous you see in which type of retinal detachment? Rhegmatogenous, tractional or serous retinal detachment. I've given you the three options. Please type in the chat box and then we will discuss the answer. Yes, very good BU. Tractional retinal detachment, traction. The fibrous bands in the vitreous and the epiretinal membrane on the retina, that is pulling, traction. That is why you're getting tractional retinal detachment. Why are you getting that? Why will you get that in rhegmatogenous retinal detachment? Yes, very good. Very good BU. See, guess very good. See, this is just common sense. Ophthalmology is just common sense. Okay, now we look at our question and now at the options. All of the following are true regarding rhegmatogenous retinal detachment except. So we had to find the false option. Yes, although when I looked at option A, detached retina is convex and irregular, I felt ki yaar, what have they asked? This question is impossible. Didn't you feel that this question is impossible? But now when you ruled out based on your knowledge, existing knowledge, when you came down to option D, you found out the correct answer. Option D is false. So that is the answer. Now, have you also learned now option A is true. The detached retina is convex and irregular. Yes, it is convex, irregular and also mobile in it, wavy and it kind of moves in rhegmatogenous retinal detachment. Is OPHTHAL interesting? It's just thoda sa you have to apply your mind. One-liners will not work. You have to think just one-liner ratta maro, to it's not going to work in OPHTHAL. OPHTHAL is very conceptual. You have to have little concepts. I mean, you have to have your concepts and you have to have a lot of common sense. Presence of mind, bas. Yes? Now, do you like this question? Do you think this question was doable? That's my whole point. Yes? Agree with me? It's doable. OPHTHAL is, what is that? Love like this. Right? You don't have to mug up anything in OPHTHAL. Konjo. Okay? Thoda sa aap apna mind apply kiya karo. It's going to be very, very easy. See, thank you, Krishna. That's how it should be. It should be interesting. Lovely. Good view. Strong. Yes, we grow strong together. Alright, shall we move to the next question? Which of the following investigations is useful to identify macular ischemia? Alright, so in the macular region, there is ischemia, ischemic maculopathy. If I had asked you a straightforward question, what is the investigation of choice for ischemic maculopathy? Probably you would have answered. Okay, let's see. Option A, OCT. See, the plain OCT will give you layer by layer visualization of the retina. Maybe indirectly some ischemic changes we can find out, but let's see if there's a better option. Option B, OCT-A, OCT angiography. Alright. Option C, fundus autofluorescence. See, autofluorescence is basically to look at your RPE layer. Yeah, RPE mein, because there is lipofuscin. So when there is a lot of lipofuscin, you have a hypofluorescence on FAF, that is fundus autofluorescence. Or if the RPE is atrophied, then you have black spots in those areas because there is no longer RPE, no longer lipofuscin. So it has nothing to do with ischemia or macular ischemia, jo bhi hai, okay? Ruled out. Pattern ERG, come on guys, pattern ERG, no, pattern ERG. Yes, it is for ganglion cell, retinal ganglion cell function, optic nerve function, pattern ERG. It is not this A wave, B wave, C wave business. That's a little different. Pattern ERG for optic nerve function. Okay, you have a checkerboard pattern which is reversed. The black and white will be reversed and it will be flashed. So pattern ERG, no way. So option is OCTA. So on OCTA, you will be able to visualize the superficial capillary network, the deep capillary network of the retina. You'll be able to visualize the choriocapillaries of the choroid, the har cheez. So when you have a macular ischemia, yes, you will see a capillary dropouts. You will see, yes, you can see an enlarged FAZ, foveal avascular zone. You can see on OCTA. What other investigation you can also use? We can also use our traditional FFA, fundus fluorescein angiography also can be used, but that's a little invasive because you're going to inject the dye and a lot of precautions are there. OCTA is non-contact, non-invasive. The patient just sits in front of the machine and within like 10-30 seconds the output is there for us to see. Okay, so the answer is OCTA, OCT angiography. Is that clear? Yes, yes, Biru. Krishna, correct. Let's move on to the next question. Which of the following is or are the mechanism of actions of ripasudil? Now, what is ripasudil? Ripasudil is one of the Rho kinase inhibitors. Yes, the ROCks. So, Rho kinase inhibitors, we know netarsudil, we know ripasudil, and there is also one fasudil, although not much in clinical use as much. So, netarsudil, yes, pretty much in use. Ripasudil, yes, in use. So we are talking about ripasudil, which of the following, and I have given a couple of options and we have to choose which combinations in the options. Okay. Option A, you tell me whether yes or no. Decreased aqueous production. Does it decrease aqueous production? Option 2, increased trabecular outflow. Option 3, increased uveoscleral outflow. Option 4, decreased episcleral venous pressure. Option 5, increased episcleral venous pressure. One thing I know, no anti-glaucoma drug can increase episcleral venous pressure. So that 5 is ruled out. Because if you increase the episcleral venous pressure, Aqueous will not flow out. You will get increased IOP and glaucoma, right? So any drug, if at all, it acts on episcleral venous pressure, it has to decrease the episcleral venous pressure. Yes, ripasudil decreases the episcleral venous pressure. Has no impact on uveoscleral outflow. Yes, it decreases the, primarily increases the trabecular outflow, decreases the episcleral venous pressure, also decreases aqueous production. 3 mechanisms, okay, 3-pronged action for Rho kinase inhibitors. So one is it increases trabecular outflow, it decreases the episcleral venous pressure, decreases the aqueous production. Is that clear? Yes, very good. Perfect. Okay, so it is 1, 2 and 4. Rho kinase inhibitors, what do? They increase trabecular outflow, decrease episcleral venous pressure and decrease the aqueous production. Is that clear? Yes, very good. Let's move on to the next question. Which of the following is a direct gonioscope? Okay, this is again a previous asked question. Option A, Goldman. See, Goldman, 1 mirror, 2 mirror, 3 mirror. They're all indirect. All these mirror wala are indirect. Remember, जो शीशे में दिखता है, जो whatever you see on the mirror is laterally reversed, kind of remember something like that, right? So all your indirect ones are mirrors, or mirrors are indirect. Yes, mirrors are indirect, indirect are mirrors, vice versa. Goldman, 1 mirror, 2 mirror, 3 mirror, indirect. My question is direct gonioscope. Posner is a 4 mirror gonioscope. 4 mirror, again indirect. Swan-Jacob, there's no mirror. I have not heard of Swan-Jacob mirror, no? Okay. Let's see the last option, Zeiss. Zeiss 4 mirror. Okay, 4 mirror. Zeiss is 4 mirror. So again, mirror indirect. So what is our answer? Answer is Swan-Jacob. Swan-Jacob is a direct gonioscope. Gonio prisms. They are gonio prisms or gonio lens. Yes. So remember, mirror MI. Okay, like MI6, MI indirect. When you have a mirror, it is indirect. Easy to remember. That's the clue. That's the trick we're going to use. Okay. So mirror mein MIRROR MI MI6. MI. So the moment you remember there's a mirror in this gonioscope, automatically there's an I, it goes to indirect. Okay. So Goldman, we have a 1 mirror, 2 mirror, 3 mirror gonioscopes. Posner is a 4 mirror. Sussman is a 4 mirror. Sussman is a 4 mirror. Okay. Zeiss is a 4 mirror. So all these are indirect. Okay. Oh, swan flies directly. Okay. Nice. I will use that also. Swan flies directly. All right. Chalo. Badhiya hai. That also is good. So if you can remember that, Krishna says the swan flies directly. Acha. Baki kya? They sit on the aeroplane and take off. Huh? Okay. Anyway, nice guys. Nice. Let's go to the next one. Periocular hyperpigmentation is a side effect of. See, when some anti-glaucoma drug, what is this periocular hyperpigmentation? So somebody is using that, they have this color pigmentation around the eye. Okay, so especially if you're going to give that kind of an anti-glaucoma drug, be very careful. Never give it for unilateral, because otherwise, at least if you have both side circles, people think, okay, it's got some black circles. It's got only on one side, it looks very cosmetically very bad. Okay, now what is this drug? I'll give you a clue. So this is something that also causes increased pigmentation of the iris, hyperchromia of the iris. Which drug is that? Which class of drug is that? Periocular hyperpigmentation is caused by the same class of drug which causes increased pigmentation of the iris. So option A, brimonidine, option B, timolol, option C, netarsodil, option D, latanoprost. Yes, PG, prostaglandin, F2 alpha analogs. Very good BU, very good Krishna. Yes, so it is latanoprost. So latanoprost can cause hyperchromia of the iris, increased pigmentation of the iris, and also periocular hyperpigmentation on a long-term use. Very good. All right. Now the last question, a 38-year-old male is on latanoprost HS, because prostaglandin analogs typically given as bedtime dose, so very convenient for the patient. OU meaning both eyes, since the last 6 years. So he's on, for 6 years he's on latanoprost. He uses +3 diopter sphere glasses. On examination, both eye findings, there is a patent peripheral iridotomy, so which means probably he had an angle closure attack for which we did a peripheral iridotomy. IOP is 32 millimeter mercury, quite high in spite of latanoprost. 270 degrees, there is peripheral anterior synechiae. That means we have done gonioscopy for this patient and we have found out that there is more around 3 quadrants. See, angle is 360 degrees. So 270 degrees or 3 quadrants. There is peripheral anterior synechiae. Fundus is normal. So that means there is no optic disc changes as yet. Perimetry, normal. Primary, what is the diagnosis? Primary open angle glaucoma. No, it cannot be open angle glaucoma. Now, the moment you have peripheral anterior synechiae, it cannot be an open angle. Yes, peripheral anterior synechiae means your iris is sticking to the cornea. That, see, when you look at through the gonioscope, what are the angle structures you visualize? You see, I can't, I'll teach you an easy mnemonic, okay? I can see till Schwalbe, that is one. You can also use I can't see that stupid line. Okay, stupid line is just Schwalbe's line. I is your iris root, the posterior most structure, ciliary body band, next scleral spur, trabecular meshwork, and your Schwalbe's, which is that stupid line, which is the most anterior structure. So when I say peripheral anterior synechiae or anterior synechiae, the iris is sticking to the cornea. The iris is sticking to the Schwalbe's line. So I can't see anything. Yes, I can't see the scleral spur. So to call an angle open, I need to see at least the scleral spur. I need to see the scleral spur. So isme 270 degrees, I can't see the scleral spur. That means angle is definitely closed. So it is definitely not primary open angle glaucoma. Primary angle closure suspect. See, in suspect, there is no synechiae. The definition of PACS. ACS is the iris and trabecular meshwork can occasionally touch. But when you indent, when you give pressure using your gonioscope, the angle will open. It may appear like the iris is touching the trabecular meshwork, but when you give pressure on your gonioscope, what we call dynamic gonioscopy, it will open up. So it's only an apposition, IT opposition, IT touch, contact, iris trabecular contact. In PACS, there is no peripheral anterior synechiae and IOP is definitely not raised. It's a honeymoon phase. The pressure is not raised. They're just dating. The pressure is not raised. Okay. So it's not PACS. Primary angle closure, that is option C. I think that is the answer. Anyway, let's look at option D. Primary angle closure glaucoma. Guys, glaucoma means permanent damage. The definition is glaucoma means you should have optic disc changes, visual field defects, and also probably some RNFL thinning which you see on OCT. It's given very clearly, fundus is normal, perimetry is normal. So this is definitely not glaucoma. So option A ruled out, it's not open angle glaucoma. Option B is ruled out, it's not PAC suspect because there is peripheral anterior synechiae, and IOP is raised. So PACS is ruled out, option D is ruled out, PACG is ruled out because there is no permanent damage of the optic disc or visual field changes. Okay, so that also is ruled out. So it's only primary angle closure. So PAC is when you have peripheral anterior synechiae, the IOP is raised, definitely raised in primary angle closure, but the optic disc is normal, the visual field changes are not there. Is that clear? Correct. Very good, BU. Very good, Krishna. All of you got this? Yes, it should be in at least 3 quadrants. Alright. Okay, so thereby we come to the end of 10 questions. Okay, guys. So I hope you found it useful and interesting. That is very important so that you don't forget whatever I have taught you now. till the exam. And to remind you, so evening we have a fundus work session at 5 baje, 5 o'clock. 6 o'clock we are going to have all the images decoded. So all the images that I posted through the last 1 week on my Instagram, so go through that so you have an idea of what I'm going to discuss, so we can discuss more. So when you contribute, it becomes very, very interesting. See, today we had Krishna telling us that Swan takes a direct flight, so Swan Jacob is a direct gonioscope, so it's nice. So go through my Instagram post through the last 1 week, and today I've already posted a fundus question for you. So 5 o'clock we will discuss we'll do the fundus work. 6 o'clock we'll do the images decoded session, and I've already given you the schedule for the next quiz, which is starting from tomorrow. So the next Telegram quiz schedule is starting from tomorrow. Routine 6 p.m. we'll do the quiz on the Telegram group, and the next morning 11 a.m. I will do the discussion for you here. You can join me at 11 or you can watch the video later. And to remind you, guys, the prices on the EyeMentor app are, incredibly low at this point. I don't know if the team can promise you anything as much low as it is now. So there is this Christmas sale going on the EyeMentor app. So including the books are also, I just realized in the morning, I don't know what kind of discount they've given. it's too low. Okay, but anyway, I think it's good for you. So you can download the app, take a look at the Christmas offers, and if you have any doubts, you can always ping me. All right. So at the end of the session, I'm feeling very happy that you all learned something good and well. All right. So you have a good Sunday. I'll see you at 5. All right. Bye-bye.